Good to see you. Hello, hello, everyone. So we're going to get started because we want to make sure that our guests, our speakers have an opportunity to really share their expertise. And so today we are going to be focusing on trust, which is part of our trust or trustworthiness series. And this is, which comes first, and this is a session 1. My name is Dr. Darlene Jenkins. I am the Senior Director of Programs at the National Healthcare for the Homeless Council. Next slide, please. And we want to just welcome you. If you are having any technical difficulties, either on our end or on your end, please send an alert to us in the chat box. We have an excellent media person with us, Brandon, who will help if possible. Of course, many ask if this session is being recorded. It is, as well as the slides will be, and the recording will be available on our website, as well as being sent to all registrants. We usually try to get it out within 3 working days. Of course, with Brandon, who is, as I said, a whiz, usually gets it out sooner. So please be expecting both the slides and recording in your email inbox within the next few days. Next slide, please. So for Zoom etiquette, we're just asking that everyone please mute themselves as you enter. And if you like, we ask you to put your camera on. It's good to see faces as we kind of scroll through. It's really good to see the different faces. But more importantly, please engage in the chat. This is an opportunity where we can interact. We want this to be a dialogue. Of course, our experts will share their thoughts and their information. But if you have a thought or you want to ask a question, please enter that in the chat. We also have the raised hand that should be at the bottom of your screen. Please utilize that if you'd like to ask your question verbally. So, and we will unmute you so that you can ask that question. So again, this is an opportunity to share ideas, to interact, to ask questions, and to learn from one another. Next slide, please. Also, when the presentation ends, we would like for you to please, when the browser closes, to please evaluate the session. This is how we are able to, really hone in on the needs. So it doesn't take more than really a minute to answer the questions. So please do that for us, and we really greatly appreciate the feedback. Next slide, please. We want to acknowledge that this session is being sponsored by the Health Resources and Services Administration, as well as the contents and opinions expressed are solely those of the presenter. And so we want to make sure that we have this acknowledgement and disclaimer up front so that everyone is clear on the ramifications by which we're presenting this. Also, we want to make sure that everyone understands that we do provide these videos as well as the webinars on our website. And so that is part of our disclaimer. Next slide, please. Our learning objectives for today, we hope that you will understand the difference between trust and trustworthiness. Also, we are going to be talking about and hopefully give an understanding of the historical context for medical mistrust. And you'll be able to identify at least one driver of mistrust. So that is the intent and the learning objectives for this session. And at the end, we will be asking if indeed these objectives were met. Next slide, please. So here are our presenters, and we're just so excited that we have Dr. Ebony Winford with us today. Dr. Winford is the Director of Research and Health Equity at Cherokee Health Systems in Knoxville, Tennessee. We have Dr. Van Yu, who is the Chief Medical Officer at the Center of Urban Community Services in New York City, New York. And then also we'll be having with us Charlotte Garner, who is one of the members of our National Community Advisory Board. And she is the regional representative, I believe, for Region 6 as well as Region 8. And she is actually from Houston, Texas. So with that introduction, I'm going to turn it over to my colleague, Ms. Tanisha Harris, who is the Clinical and Quality Manager for the Council. Tanisha?
Thank you so much, Darlene. Thank you so much. I really appreciate it. Thank you all so much for joining us today. So good afternoon. Um, I would like to just take some time to set the stage for our webinar today. Trust and trustworthiness, which comes first? COVID has undoubtedly shown us once again how marginalized communities and the hardly reached population suffers despite our increasing conversations around health equity. COVID has also brought to light the severity of and the gravity of mistrust amongst individuals and organizations. So, which actually comes first, trust or trustworthiness? I want to begin by highlighting some of the current conversations around increasing trust. And these conversations began to take deeper dives due to the inequities and disparities of COVID, and of course, the current racial climate in America. Three big conversations are happening, and these conversations are very necessary and very vital. One conversation is around the unethical practices by systems directed at Black, Indigenous, and people of color. And by systems, we mean our clinical, our research, and our healthcare systems. The African American population makes up around 13% of the United States population, but has accounted for 21% of deaths from COVID. The African American population has borne a disproportionate burden of COVID cases and COVID deaths. A 2017 study found that 32% of African Americans, 25% of Latinas, 14% of Latinos, and 16% of the LGBTQ population reported experiencing discrimination seeking care from a doctor or health clinic. Another big conversation is the politicization of the vaccine development. This conversation has given rise to widespread mistrust amongst the general public. There was even a joint pledge by 9 pharmaceutical companies that they would stand with science and submit a vaccine for approval that is convincing to the general public. But in the words of the National Academies of Science, it must also be convincing by audiences who are socioeconomically, culturally, and educationally diverse, those who have historical, distinct experiences. And of course, a conversation that we've had around the extreme levels of distrust in our healthcare system. So I would like to look at some data really quickly. This is from the study, the Survey of Race and Health. It was a joint project between the Kaiser Family Foundation and ESPN's The Undefeated. It explored the public's views and experiences on topics of healthcare, racial discrimination, the pandemic, but with a special focus on Black adults. The project focused on African Americans' views and experiences of being Black in America, including views of unconscious bias, structural racism, experiences of discrimination within and outside of our healthcare systems, trust in the healthcare system, social and economic impacts of the pandemic, and views of the vaccine. If you look at the graph here, you will see that 37% of Black mothers say that in the last few months of the year of 2020, they felt they were treated unfairly while getting healthcare because of their race or ethnic background. And here, from the same survey, you can see that 70% of Black adults say the healthcare system often treats people unfairly based on their race or ethnic background. 65% say it's difficult to find a doctor who shares their experience or their background. 79% say systemic or structural racism is a major obstacle to achieving equal outcomes. So how did we get here? And how can we move forward? Let's look at trust. Trust is the firm belief in the character, strength, or truth of someone or something, a person or thing in which confidence is placed. Let's think about that definition. A firm belief in the character, a firm belief in the strength, a firm belief belief in the truth of someone or something, an individual, an organization, a system. What would make you lose trust? Let's look at the drivers of mistrust: historical trauma, legacies of abuse and mistreatment, present-day social and economic inequities, and experience of racism, discrimination, and stigma. The next slides are illustrations of these drivers. On the left, the U.S. Public Health Service syphilis study at Tuskegee, often identified as a barrier to participation in biomedical research, particularly within the African American community. The U.S. Public Health Service syphilis study in 1932 involved a project that involved 399 men with syphilis. The men were told that they were being treated for bad blood. Researchers requested that local physicians withhold treatment from their study subjects, and the decision was made to follow these men unto death. Even though penicillin was the drug of choice for syphilis, the researchers decided to not treat the men. The U.S. Public Health Service syphilis study at Tuskegee violated basic bioethical principles. The participants were not fully informed in order to make autonomous decisions. The participants were harmed because treatment was withheld even after it became treatment of choice, and only African Americans were recruited. As you can imagine, the lives of these men were told and passed down from generation to generation. And this study still holds great implications of medical mistrust to date. And on the right, Mrs. Henrietta Lacks, another illustration of the inequities in our research and healthcare systems. In 1951, Mrs. Henrietta Lacks visited the Johns Hopkins Hospital complaining of bleeding. Upon examination, researchers discovered a large malignant tumor on her cervix. Medical records showed that Mrs. Lacks began undergoing treatments for her cervical cancer, and a sample of her cancer cells were retrieved during a biopsy without her knowledge and without her consent. Researchers discovered that Mrs. Lacks' cells were like any other. As where other cells would die, Mrs. Lacks' cells would double every 20 to 24 hours. Mrs. Lacks' incredible cells, called the HeLa cells, have been used to study the effects of toxins, drugs, hormones, viruses. They've been used to test the effects of radiations, poisons, to study the Human Genome Project, and played a crucial role in the development of the polio vaccine. Mrs. Lacks ultimately passed away on October 4, 1951, at 31. What about currently? December 23, 2020, Dr. Suzanne Moore, a medical physician, asked and begged for help while being hospitalized for COVID. She died no more than 2 weeks after being released. She recorded her mistreatment and said, "I put forth and I maintain that if I were white, I wouldn't have gone through that." Even more currently, volunteers and protesters painting the Black Lives Matter street mural. Or April 11, 2021, where Dwayne Wright was shot and killed during a routine traffic stop. These illustrations of the drivers of mistrust, historical trauma, legacies of abuse and mistreatment, and the constant experience of racism, discrimination, and stigma offer a disheartening picture of our system. How could you trust a system that has seemed to fail you repeatedly? If you don't prove to be trustworthy, you can't be trusted. Thank you.
Great, thank you, Tanisha. Now we're going to move into our discussion period. We're going to ask our guests to join us at this time, Dr. Winford, Dr. Yu, and Ms. Gardner. You've heard some of the historical ramifications that Tanisha has put out for us. So would any of you first like to start with a reaction or addition to what has been presented thus far?
I'm happy to reflect on what's been presented. My heart gets heavy always when you think about the history that people who look like me have endured simply because they look like me. But I would be remiss if I didn't acknowledge that a 15 or 16-year-old girl, we haven't quite confirmed yet, was killed within the exact same hour as the Derek Chauvin trial yesterday, on camera. And she called the police for help and ended up dead by the gun of a police officer. I'm currently in Memphis, Tennessee, visiting one of our clinics here, but my home base is typically Knoxville, Tennessee, which you may have heard of this week as well. We have lost five students from the exact same high school, which is a block away from the clinic where I work, since January. All Black, all due to violence. The most recent one was shot by a police officer last Monday, actually. It's overwhelming. And even though we had this rare occasion yesterday where the legal system provided 3 guilty verdicts, it's not justice, right? It's accountability, because if it were justice, Black men in particular wouldn't be dead or wouldn't die at disproportionate rates compared to their white counterparts. We'd have people alive. We wouldn't have murals. We wouldn't have hashtags. We wouldn't have t-shirts and memorials and flowers. People like my nephew and my brother and my husband could actually grow old if it was justice. And so whenever I read or hear or am reminded of this history of abusing bodies because they look like mine, it's overwhelming. And if you sit with it too long, you can go down a deep, dark hole, and I refuse to let myself go that far, but I gotta acknowledge that it's overwhelming to consider all of that at once, and it's necessary to frame this conversation within that context. So I thank you, Tanisha, for doing just that, and it's overwhelming.
Thank you, Dr. Winford, for sharing. Dr. Yu, do you have anything you'd like to share at this time?
Yeah, I think it's great that this conversation about, I think we're talking about vaccines, maybe more specifically, but I think care in general is being framed as an issue of trust, right? And not as an issue of like knowledge or education or something like that. Not that those things aren't also important, but I think at the end of the day, people make decisions about their healthcare based on whether they trust the person offering it to them or the system offering to them or not, right? Mm-hmm. And so I think if you're not mindful and intentional about this issue as a provider, as I'm a physician, as a provider, then you're not going to be a very effective provider, right? So I think this is the right framing of this issue, or it's a good framing of this issue, and it's really valuable. So that's my first reaction to all of this.
Well, thank you. Yeah, and that's one of the reasons why we wanted to do this, is because the council has been tasked to really try to increase vaccine acceptance among people experiencing homelessness, right? But again, in order to increase the acceptance of something, you have to look at the context by which you're talking. You have to really understand that just because you say come, if you build something, yes, say come, that does not necessarily mean that people will come and be part of that, even if it may be the best thing for them, right? We know that the vaccine is good and we want to prevent people from getting COVID, but unless you understand just the type of trauma that especially people of color, as well as people experiencing homelessness, have endured, it's not as easy for them to come and partake within a system that have not received the best treatment, right? So let's shift our conversation a little bit and talk about people experiencing homelessness and that whole trust relationship. For a person who may be unstably housed, what type of trust issues may they have?
I would like to speak. As being the only person on the panel here with actual lived experience and being a formerly homeless individual, first of all, I would like to thank Tanisha for her bravery and for her ingenuity in bringing this forum where this conversation can continue and even elevate on a different and more in-depth level. So I thank you, Tanisha. Now, my response to which came first, she did a good presentation of laying a good foundation, because you definitely have to exemplify trustworthiness in order to gain trust. Trust is never a given. It's always an earned thing. In the form of medical health care and those different things, number one, we put people with labels. We say homeless, we say marginalized, we say African American, I say Black. I don't use African American. So we say these things. Automatically, there's a perception and a categorization that goes with the label. So there is a prejudice or a preconceived notion about these people already. If you are a part of any of those categories, then you already know that a stigma is attached to you simply because you are that way. If you have been traumatized in your lifetime, then also you have been a victim. How people process trauma is up to the individual. Some people can handle stuff fast. Some people, it takes a long time to get over things. But the longer it takes you to recover from trauma, the longer you remain in victim stance. So when we are approaching, I mean the homeless community, I mean Blacks, I mean marginalized people. When we are approaching for services, we already come in with all of these things in the back of our mind. Whether or not the provider if it's in the forefront of the provider's mind, we automatically assume that it is not. We know that the need is great for services. However, the availability does not match the need. That's nobody's fault, because every day something new is happening. Doors are open, ways are being made to reach out to people in need. But if we would kind of make a more concerted effort to stop categorizing, labeling, and stigmatizing people. It's an awesome responsibility for a provider to have this in the forefront of this mind. But if you're dealing with people who fit those categories, then it's a must that you do think that when they come in, they're already defensive, they're already offended, and anything can become a barrier to you being able to provide them with what you know they need.
Great. Thank you so much, Charlotte, especially bringing up that conversation about how we label people. So often we also label people by saying they're hard to reach. And anytime you say that a person is hard to reach, then that gives you an opportunity to say, well, I tried, but they're so hard to reach, I couldn't get to them. I'm sure my cable company says I'm hard to reach because every time they call, I don't answer their phone. It's not because I'm not hard to reach. It's because, number one, what they may be offering may not be what I need at that time, or what they're talking about may not be what I want to hear at that time. And so we really do have to be careful on how we label people and that we're not already striking or saying that we don't have to make the effort because they fall into a certain category that we placed them in. So thank you for that. Yeah, would anyone else, Dr. Winford, Dr. Yu, have anything, a response or any thing? And then we'll go to our chat box just to see if there's any questions.
Yeah, I'll say something quick about the homelessness issue and pick up on, Charlotte is making a point about this sort of the structural context that a person who's seeking services at a homeless services provider is in, that right away puts up a barrier, right? That, so I'm a psychiatrist, right? And our agency offers, psychiatric and medical care to people who are homeless, right? And oftentimes we're encountering people for whom, their psychiatric condition is like very low on their priority list of things they care about today, right? So I spend a lot of my time trying to convince people that I've got something for them, right? And if, and for what it's worth, if the person doesn't accept the thing I have to offer, like I've learned not to conceptualize that as they're hard to reach. I conceptualize that as I failed, right? To convince that person, right? And I ask myself, okay, why did I fail, right? And I'll say this one last thing before I'll stop for now, is that, and I think one of the reasons I fail is because of what I look like, right? That, I have the privilege and the opportunity to, like, it happens to be my primary care provider is also Asian American. I get to go see a provider who looks like me, right? It's not the reason I picked him, but it just so happens he is, right? But not only does the people who I offer to serve, almost none of them look like me, right? And like I'm it, like they don't really have a choice in the places where they're meeting me because I'm the only person there who's offering the specific service I'm offering. So that right away they're in this position of, I'm not sure exactly right, but vis-a-vis me, that's sort of a strained position, I'd say. It's, I think, a fair way to say it. So as an offer of care, I have to grapple with that intentionally. Otherwise, that person's not accepting a COVID vaccine for me unless I figure out a way to grapple with that in an effective way.
Yeah. And tell us, how do you do that, Dr. Yu? And then we'll move to Dr. Winford. How do you do that?
Yeah. So it's actually, from my point of view, it's a pretty simple concept, which is that if the person's got to believe three things, right? And then I'll tell you the three things, and I'll tell you how I get the person to try to believe that. They got to believe that I understand whatever their concern is, that I care about whatever that concern is, and that I want to do something about it, right? And so, but that starts with, like, I got to understand the concern. So it starts with, I ask about it. Like, well, what is your, if you're having a concern, tell me, what is it? And the person has to believe that I really want to know, right? Which means I really have to listen and right, and try to have empathy for the person I'm sitting in the room with, right? And not assume that I understand what the concern is, by the way, right? That, I can walk into the room and make all kinds of assumptions about what the concern might be just by the way the person looks. And I'm always wrong if I do that, right? And people have surprised me with all, every person has a different concern about, if we're talking about vaccines specifically, every person has a different, unpredictable to me concern. So I gotta be open to whatever that is and not have a preconceived notion about what it might be. So that's where it starts, is being curious and open to whatever is the situation, what it really is.
Great, thank you. Dr. Winford?
I just want to highlight my appreciation for our attention to language and the onus of responsibility. When we're talking about, vaccine acceptance and uptake, it's framed within the context of hesitancy. And that puts the onus on the person to become less hesitant instead of the system to become more trustworthy. And so I think that was one of the biggest reasons why I was intrigued by the way we frame this conversation, is that we're focusing on how do we as healthcare providers, I'm a licensed psychologist, how do we become trustworthy, not how do people become less hesitant, because that's not on them. It's on us, the people who are in positions of power and authority, whether it's real or perceived. We need to change the system and the language that we use. And so I'm reflecting very strongly on those things and the challenges. How do we become trustworthy members of the care team?
Right. Thank you. And that is a great plug for our session 2, when we will be talking next week about the principles of trustworthiness. So thank you for that. We wanted to focus on trust first and really point out how trust is earned, as I think Charlotte so eloquently said. And then once we understand that we have to earn it, then we have to talk about how we become more trustworthy. And so that is the second part of what our conversation will be. Charlotte, did you have anything you would like to add? And then for those who are on the webinar, will you please utilize the chat if you have any questions for our presenters, or you have any insight, raise your hand. We now invite you to do so at this time. Charlotte, would you like to share something? And then we'll go to the chat.
Mm-hmm. Thank you so much. Dr. Yu, I love what you said. And it very much is actually the bridge that would make the connection. I'll tell you a little bit about my story. I entered healthcare for the homeless Houston with 32 cents and the clothes on my back. I was given a case manager, and try as I may, you know, she kept giving me these resource guides with every single solitary resource that you could imagine, you know, everything, because she asked me, what did I need? And I kept saying everything. I was unable to specifically articulate my needs to her. However, she could feel that I had a need, so she didn't stop trying to reach me. And although I would have different traumatic relapses and fall off the wagon, I kept coming back. So I asked her one day, why is it that you kept helping me when I kept messing up my opportunities? And she just simply said to me, because you kept coming back. And that let me know that you really wanted help. So maybe that might be something that you can look for, because the help, you'll never reach those who need it, but you can reach those who really want it, because they will put forth the extra effort in your eyesight to let you know that they're willing to go the extra mile to get it. And Dr. Winford, I want to say something to you about your disdain for the climate. Hold on to that. My pastor told me, he said, when these igniting events happen, these large, that they play out in the national media, everybody's angry, everybody's upset, everybody's thrown off by it. But the moment it subsides, everybody goes back. So if we were satisfied with what happened yesterday in the verdict, we were not angry enough for change. So I just wanted to give you that. And I appreciate your starting this whole thing off with your response, because it was a response, it wasn't a reaction. So I hope that in some small way, I gave some insight into the mindset of the homeless individual, the marginalized individual. And I'll tell both of you that I have been under psychiatric care for nearly 40 years, and I have a bachelor's of science in psychology, so I could help y'all fix me.
Great. Thank you so much, Charlotte. I'm seeing some comments now in the chat, and thank you all for who are putting comments. One comment, of course, Dr. Yu is saying, someone said that they really greatly appreciate your what you had stated, because it's a great approach to cultural humility, really practicing cultural humility and understanding that role. We're having some audio problems. I'm not sure if we're still, I'm not hearing it, but there's some saying that there's choppy. So Brandon, I don't know if we can correct that or not, but if we can kind of check something, I would appreciate it. Also, Dr. Winford, someone has given a shout out to you regarding your statement on it's not the person's responsibility to become less hesitant, it's our responsibility to become more trustworthy. So thank you for that. Someone said that they would like to hear you talk about how systems, including jails, okay, please talk about how systems, including jails, psych hospitals, and emergency departments have contributed to mistrust, especially for people experiencing homelessness. Who would like to share their experience regarding how this has contributed, those systems have contributed to mistrust?
I'll say something brief, especially as it relates to hospitals. When the homeless plight began to spread, to really be noticeable and grow, the homeless community sought hospitals as a shelter. And so they would go to ERs, what have you. But thank God for the ingenuity of someone who said, we have to find a way to treat these people outside of that system. But those people were not welcome in those places. In jails, you have a situation there that you can come in, you can say, you know, I'm homeless. And they are like, well, you are been rescued, so we really don't need to do anything to help you. You just enjoy your stay here. You know, at least you're getting 3 hots and a cot, you know. So that type of ideology, you know, like I say, it goes back to being labeled, being categorized, you know, and being put in a box. And it's very difficult to get out of that box when the widespread opinion, the overwhelming opinion and the consensus all goes the same way.
So maybe I'll pick up on that, Charlotte, and call out my profession a little bit, right? That I think, certainly in the States, we physicians are trained really well on the medicine, meaning the medical issues, right? Like, you know, I think American trained doctors are among the most medically educated people in the world, right? What we're not so well trained, at least not where I went to school and training, is about how to, you know, create effective healthcare relationships with our patients, right? It's like this weird omission in our training. I think maybe prior to, you know, my day, this was more of a central topic of medical training, but it wasn't when I was training and in school. Part of it's just because there's so much medicine to learn. There's like, in a way, this is not an excuse. There's like sort of not the time that isn't prioritized because there's other things to do, right? And then I think a result of that is that a lot of physicians, they're not that good at like interacting with their patients because they were never really taught how to do it, and it wasn't prioritized, right? It wasn't like, it's not like a thing in their head to like prioritize it, right? I was lucky. I had some good mentors, and it's like that I was able to model myself after, not so mindfully or intentionally, but I got lucky. And then I do think to give some people the benefit of the doubt, I do think people who work in my sector, you know, physicians who are offering care to people who are homeless and in that system, are better at this because we end up doing this kind of work because we care about that, right? It's not the only place that people who care about it end up, but it's one of the places, right? But I tell you, I finished my training 20 years ago, and I'm still learning how to do it, right? I'm still like almost every time I see patients, I catch myself doing something where I think, yeah, that wasn't the best way to talk to that person, right? So that's the other thing. It's right. I think it requires a person to be open to seeing how they're still not doing it as well as they want to, right? As far as we providers are concerned. Anyway, so but back to your question, Darlene, if I'm remembering the question correctly, is so I think that contributes to the experience people have in these systems. I can't speak to the forensic system so much, but the hospital system I can certainly speak to. I used to work in a hospital. That it's not the only thing that contributes to the feeling, but it's one of them, right? It's just this, you know, that just that structure kind of robs the humanity, or at least part of the humanity, of these interactions that people are having with each other. It's like doctor-patient. There's a little bit of a depersonalization in even that framing of it, right? Which it's not totally people's fault, but it does contribute to it, right? And then for the doctors, like they do it every day. It's just sort of like natural for them. But for the person who's receiving care or there to receive care, it's not like it must feel weird, right? For one thing, and disorienting, and depersonalizing. So that's one of the things we're up against, I think.
Yeah, great, thank you. Doctor, there's someone here that mentioned they're a newer doctor, and the person states, we are trained, this is from Jessica, thank you, Jessica, we are trained to pathologize individuals, not systems, and we are not trained to do strength-based assessment of individuals. And that's
well
what it
put.
is.
Yes, better put than I just put it, so thank you for that.
Yes, exactly. Here's a question, how has COVID-19 challenged or presented the opportunity for trust building?
It took away the literal personal touch because of real fear of exposure and transmission. You know, like you might be able to go into communities with cultural brokers and inform partnerships and relationships, but when the world stopped, the world stopped. And if you don't have like access to technology, including internet or internet enabled device, then you couldn't access the people who may have had any resources to assist you, because literally the personal connection stopped. And even now, like I've been fully vaccinated, thank goodness, since January, but there's even still like fear, like, am I allowed to have my mask off right now? You know, like, should I be doing this? But I think the fact that we literally had to separate, that physical distancing really took away some of the opportunities for us to make connections and partnerships and build relationships, which I think are important and necessary for trust building in any community. And I'm a big fan of the community-based participatory, like healthcare and community health. Like I can't just come to your neighborhood and be like, I'm gonna come fix you. But in the absence of being able to be there and spend time with individuals because of the need to be safe, you lose opportunities to build trust and relationship. And I think that's one of the key things from my perspective. Give me 2 seconds just to go back. I think one thing we need to name explicitly when we think about how jails and hospitals and ERs have contributed to lack of distrust. Whenever we think about mental health and behavioral health, it has become criminalized. And those are 3 sources of criminal labeling of normal continuums of wellness. And when you present for care in a pandemic or not, but the police are the ones that are called to give you help, why would you trust people? Like it literally makes no sense for people to trust you if that is the context in which your help-seeking behavior is treated, if it's then become criminalized.
Excellent point. Thank you so much, Dr. Winford. I'm going to go back up here. I said, I see a question. It says, I've noticed that opening by normalizing concerns, a lot of clients have mentioned X concern helps open the door. Of course, oh, this is a statement. Of course, this relies on assumptions that what concerns clients may have, so it's not perfect. Thoughts on what language. Oh, so the question is thoughts on what language to use in vaccine conversations or on this technique in general. So what opening the conversation with talking to a person regarding the language on vaccine conversations? What's the best technique to use?
I put in the chat box that I actually think that's a good technique. Like, first ask, what are your concerns? Like, don't assume what the concerns are, but I've found that learning that you're not weird and you're not the only one having similar concerns is an intervention in and of itself. And we're finding, if we think about like the curve of adoption of things, we have some early adopters, me. I got vaccinated within 50 minutes of getting the email that I was allowed to be vaccinated. Like, I ran. And then there are the late adopters / you're right, that's cute. And then there are the ones in the middle. And the ones in the middle are in like contemplation stage of change, or like considering things. That's where the money is. So if somebody needs to know that others like them in that stage of contemplation change are also having those concerns, you better believe I'm gonna say, well, you know what other people have told me, right? But I'm gonna ask first, like, what's your biggest concern? And I might follow with, well, you know, that's not uncommon. I've spoken to a lot of people who share some similar things. What are your thoughts about blah, blah, blah? So I actually think you were right spot on with normalizing it and recognizing that just knowing we're not weird helps a whole lot.
Yeah. I have to say, I was one who was a delayed decision maker, right? Even though I have a doctorate in public health. I mean, public health is my bloodline, right? This is my profession as a public health practitioner. When I was, heard about the vaccination opportunity, I was delayed. I was not sure I wanted to get it, right? And so I think what helped me was when we're giving information, the intent should not be try to push someone to get the vaccination, right? It's to give them as much information as possible so that they can make the best informed decision for themselves. And I think that's what helped me. I read, I studied, I talked to friends. I saw a posting of friends on Facebook who had gotten the vaccine, who didn't have any adverse effects. My parents got vaccinated. They're both in their 90s. And so of course I asked them, they were first on my list, go and get your vaccinations. And my mother was sick a little, but I mean, they both did excellent. So again, I think that it's very important that you do listen and hear and be able to recall and to give people, be very transparent with what is the effects, what is what you may be experiencing, what people have said, and really give them the information so that they can make an informed decision on that. So that's
I think and I say this to people, my job isn't to convince you, my job is to help you decide what's best for you and your family, right? I mean, I'm upfront about what my opinion is, right? But it's not my job to strong arm you. I mean, there's enough of that in the system. I'm not interested in it, right? And I think it's an iterative process. You can go back to the question, what's the language? To me, it's like not even a question of like, what language do I use? I mean, I pitch it to whoever I'm talking to, right? But it's, I say something and I say, okay, does that make sense to you or not? Right. And if it doesn't, like, tell me why it doesn't make sense so I can adjust what I'm saying to you in a way that to moves the conversation forward. Right. And I'll add one more thing. And I think part of this iterativeness of the process and the back and forth with the person you're talking to is to also just be upfront about what you don't know. I mean, that was very present, especially this time last year in the March, April, May of 2020. There were still so many unknowns. And one of the things I was doing was communicating to staff and clients about like, what is going on around us. And a lot of what I was saying is like, well, here's what we don't know, right? Let's be clear about that, right? And then, but here's what we do know, and here's what we believe is going on, right? And so also just being upfront about, if someone asks me a question about a vaccine and I don't know the answer, I just say, that's a really good question. I don't know the answer to that. Let me get back. I'm not going to make something up, right? And that, I think that contributes to the conversation. Again, the person's got to feel like, I think the person has to feel like you're in a conversation with them. It's not me like lecturing, right? Or shaking my finger, right?
Exactly. We're down to about 9 minutes. So I want to make sure that I covered another question that was given. What are your thoughts on the role of community health workers or patient advocates play in increasing trust between individuals and the healthcare system? Who would like to answer this question? Charlotte, I see you trying. Yep. Mm-hmm.
Yes. Liaisons, especially if liaisons with common backgrounds. You know what I'm saying? But then liaisons, it's just that the object is for the other person to feel on the same level. You understand? Whereas I may not be as intimidated talking to my case manager, my community health worker, the patient advocate, because I have a clear enough understanding of their role that it is to assist me or to speak for me or to mediate for me. So that takes some of the being overwhelmed by the authority of the other person. You know, the individual always has to feel as though they have a choice. This is a choice for me. You're not trying to make this decision for me. You're not trying to force your opinion on me. So I think that advocacy and community health workers, those people who we have the most interaction with because they are the front line, tend to have the greatest opportunity to set the tone for what that organization is or what it represents because we meet them first.
All right. Thank you so much. Thank you. And Dr. Winford, of course, put in the chat, lived experience is everything. That's exactly right. And someone said, and prioritizing lived experience of homelessness, trauma, behavioral health struggles, racism, et cetera, in the hiring process throughout the hierarchy, not only as peer specialists, is important. Thank you for sharing that information as well. So as we go down to our last 7 minutes, Tanisha, would you like to say something as we kind of finish up, and then we'll give our presenters possibly the last word of what wisdom they'd like to leave with our audience?
Absolutely. I just want to thank all of you all for being here. Dr. Yu, Dr. Winford, and Ms. Charlotte, thank you so much for lending your experience and expertise to this conversation. I am excited about continuing this conversation with our extended webinar, and for all of our panelists. Again, thank you so much for your participation. I look forward to continuing this conversation with you all.
Great, thank you. So with parting words of wisdom, I will start with Dr. Yu. What are your parting words of wisdom for the audience as we go out and we're talking about trust? And again, I want to remind you, this is our first session on our series. Next week, we will be talking about trustworthiness. But as we go forward, what is your last and final words about trust and the importance of building that trust or recognizing trust, the need for trust?
Yeah, I mean, I think it seemed to me the assumption here, which I would agree with, is that trustworthiness precedes trust, right? And we have a saying around at our place that the relationship is the treatment, right? And back to your question about, advocates, I've been thinking about that a lot recently because we're trying to cook up a model to go into the shelters to help people make these decisions about vaccines. And one of the questions I have is, are people going to accept vaccines or vaccine recommendations from somebody they don't already know? Right. And that's a real question that I have. I'm not sure what the answer is. But if the answer is no, they're not, then I think the challenge for us, and this goes back to the trustworthiness issue, is okay, then we have to be we got to become people who they already know. And so that's the challenge.
Great, thank you. Ms. Charlotte, what are your parting words for that? For that?
Well, I would just say that perspective is everything. Everybody has one. And so we need to value each other's perspective. That old adage, do unto others as you would have them to do unto you. I need to be empathetically empowered so that I can see you through your eyes, not mine.
Great, thank you. Thank you so much for that. And Dr. Ebony, take us out with some words of wisdom for us.
No pressure. So I've been trying to reflect quickly after these little nuggets that were dropped. But here's the thing that stands out most powerfully for me. Our shared humanity is, I think, one of the things that forms the basis of any trust or any relationship. And if we, as healthcare providers, can't tap into our own humanity and shared struggles, shared successes. And we have no right being in this role, first of all. But secondly, that does not lend itself to trust or trustworthiness. And so for those with lived experience for whom we're trying to partner and help, if we come across as experts rather than people, we lose our shot before we start. And I just want to highlight our common humanity as the core basis to a trustworthy relationship.
Great. Thank you. Thank you all for that information. Tanisha, I'll turn it back over to you. Did you have a final slide that you wanted to share? So these are our presenters for next week, and it's going to be the same time. And we'll be talking about how to be trustworthy. So please join us. Next slide, please. These are resources that we'd like to share with you more on the topic, and that you can learn more about trust as well as trustworthiness. And next slide, please. And then follow us on social media. We, the National Healthcare for the Homeless Council, as well as we have a National Institute for Medical Respite Care. And these are Twitter and Facebook, as well as on YouTube. That's where you can find a lot of our webinars posted on YouTube on our channel there. So please take advantage of that. Reach out to us if you have any questions about the webinar, and if you'd like to get in contact with the presenters. We are so fortunate to have a wonderful relationship with Dr. Yu and Dr. Winford, as well as Ms. Charlotte. They are part of our community. They're part of our the council family. And so we are very fortunate to have them with us in many initiatives. And so reach out if you have any additional questions, or if you would like to have future conversations with these experts. And with that, I think we're going to sign off. Do you have any parting words, Tanisha, before we go?
Again, just a sincere thanks. Thanks for the openness, for the conversation. I sincerely appreciate it.
And the final word is yes, the link will be sent out along with the slides. And the next webinar will be next Wednesday, April 28th at 2 p.m. Eastern, 1 p.m. Central Time. And the link that you use to register for this webinar is the same link that you will register for the next webinar. So thank you so much. Enjoy the rest of your day, and everyone, please be safe and take care of yourselves. Bye-bye.